Hi, everyone. Welcome to the December webinar. We'll give it just a minute here and let everybody join in, and then we'll get started and talk a little bit about the 2025 AHA guidelines. Dr. Ray, good afternoon.
Yes, it feels like it's a big afternoon. We got our Seahawks on the docket this evening.
It is indeed. Yeah, it's a big game. I'll be working in the ER this afternoon, so
Oh,
hopefully
you
no
will.
players get injured and come visit me.
Yeah, hopefully not.
That is always the event of the day when
Yeah.
every athletically related doctor in the world shows up to help.
That's right. They're anxious to help out.
Anxious to help out. We'll just leave it at that.
Very good. Well, yeah, hopefully you won't have to deal with any of the Seahawk revelers later on.
Oh, I'm sure someone will climb on a Lime scooter and succumb to the mean and bumpy streets of Seattle on said Lime scooter with the
Wet,
early
wet and
days.
slippery, wet and slippery street.
Exactly. Yeah, that's been the common mechanism of injury lately.
Yeah.
That's pretty wild. Well, let's go ahead and get started. I prepared a few slides to just go over some of what I see as highlights in the 2025 AHA guidelines. I've invited Tom and Michael, and please jump in with questions. We're this is a bit of a free form session. I'll go through some of what I think is interesting, and then if questions from the audience, I'll ask Michael and Tom what they think are kind of interesting and might move the needle on practice a little bit, kind of topics, and kind of see where we go and hopefully have a fun afternoon. So let's take it away from here. I'm going to try a new Zoom trick. There we go. Look at that. We can pop. Yeah. You like that? Isn't that amazing?
Wow,
Isn't that
McCoy
amazing?
levels up in Zoom.
I mean, easy one way or the other. All right, let's rock and roll. A little bit here, no real conflicts of interest. I, along with Tom and Michael, attended the Cardiac Arrest Survival Summit. And if you haven't been to this event, it really was pretty awesome. It was the first one that I've attended, and really just a different group of people, all really interested in improving the care of patients with cardiac arrest. And a lot of folks who attend this webinar are key and critical participants in the organization of this, and might be board members, and really an excellent time. So I think the next time it'll be held is I think every 2 years, so 2027. So look for that, and we'll promote it. It was pretty awesome time, and get to see a lot of friends and a lot of people doing work very adjacent to what we do. Pretty cool stuff. Talk a little bit about where the guidelines come from. So the ILCOR work is done on a continuous basis, and this is work where the evidence is continually evaluated. For the 2025 cycle, there were over 380 contributors as part of the evidence evaluation. And this is done regularly over the years between guideline cycles. The estimate from ILCOR, assisted by ChatGPT, is somewhere in the neighborhood of 50 to 100,000 person hours per 5-year cycle. So really a tremendous effort. Peter Kudenchuk is very involved in this, along with several other of our faculty. Um, in terms of products, 137 systematic reviews prior to the 2025 guidelines, 82 scoping reviews. And then ILCOR uses these evidence to decision sheets to really define the work that's out there and what's new. And hundreds of these, basically innumerable number of these were created. So super interesting. One comment, I can see only the speaker and not the content. So maybe I'll turn off my fancy features and see if that helps or not. I don't know. See if that helped. Um, Keep going. Then the Heart Association takes the ILCOR guidelines, right, and makes them, for lack of a better term, American, right? This is the American version, American adaptation. This consisted of 9 writing groups, 12 to 15 members each, around 150 authors across all of the recommendations and all of the writing groups. This took place over 3 years, prior to publication on October 22nd, 2025. So just a few weeks ago. Really exciting work here and pretty,
McCoy,
yeah.
several people in the chat. Yeah, there you go. Thank
We'll
you.
see if that helps. I don't know if that'll actually help or not, but we'll give it a go. We're trying a new feature there and just flopping, so we gave it a go. 760 total recommendations out of this work, right? 233 are class one, which have good evidence to support it. 451 are class two, maybe a little less evidence to support, but still something to come out in favor of, and then 76 class three recommendations. AHA guideline sections this year are a bit different. So you'll see a few more sort of sections as you dive into reading these guidelines. And
Hey, Andy, can you reshare your slides?
yeah, let's try that.
Or at least I'm not seeing them. Maybe others are seeing them, but I didn't see them.
I was seeing him fine. It's you, so, right?
Oh, okay. Well, I see them now, so that's
There we
great.
go. All right, we fixed it, perhaps. All right. A little bit of a reorganization here with the sort of the sections of the guidelines, splitting out pediatric and adult in the basic life support and advanced life support categories, and adding a couple sort of new big topics, big picture topics, which I think is really setting the framework up for not only this guideline cycle, but for the future with sort of where we're headed with the evolution of the research. The other new thing is the chain of survival, right? Previously, we had not one, not two, not three, but four different chains of survival that all sort of represented things. Those have all been brought together and coalesced around the chain of survival that you see in front of you, which is now the one AHA chain of survival as we talk about this concept within resuscitation and within our work. So a little bit about what do we care about? We're going to talk briefly about mechanical CPR. We'll talk about the guidelines around dual sequential defibrillation, vector change. We'll talk about the statement on head-up CPR that made it in the guidelines. Talk a little bit about the medications we use, and then a little bit around sort of some special populations and post-arrest work that went in there. And I added a couple other exciting topics lately, so it should be good. And then chime in with some of our experts, and hopefully all of you can throw your questions in the chat or in the Q&A, and we'll take it from there and feel free to comment. I did ask Chat GPT to give me a very basic version of these updates, and it really went wild with this. So for those of you who understand the graphics and how they're made, not a ton of time to try to fix this one, but it was just kind of wild here. So pretty interesting stuff. Uh we'll skip over that and keep going. So been a lot of hot reactions out there, right? And for those of you who peruse the blogosphere or social media or these sorts of things, I think the point that really caught the most attention in social media was around mechanical CPR. And this to me, I think was a little bit interesting because, I didn't see a huge change in the wording, and I didn't see sort of a huge implementation change in what came from American Heart Association in the guidelines. And more, I saw sort of a little bit of evolution of understanding how these devices are actually used in the real world. And wanted to talk briefly about this. And these are, I mean, hot reactions, right? This is the hill I want to die on, right? I find it incredibly disappointing. These are strong words from our EMS community out there in reaction to the Heart Association's guidelines. And so what were the changes? So the wording in 2024, mechanical CPR devices, the use may be considered, right? And in 2025, the update is routine use is not recommended, right? Now remember, guidelines follow the evidence, right? And so what's the evidence for mechanical CPR devices? Well, it's all in EMS, right? Very, very little in any setting outside of EMS. And in all of the papers that have been studied, been published, and all of the trials that have been done, all the randomized trials, right? We have no trial that shows that mechanical CPR is better than well-performed high-performance CPR by a human, right? So not a huge change here from my perspective, right? They did leave the door open, right? Both sets of guidelines, 2020 and 2025, allow for sort of special circumstances. Special circumstances are times when manual compressions, high-quality manual compressions, are not possible. whether that's moving a patient, whether that's a patient who rearrests en route to the hospital, and you're trying to sort of both drive and provide resuscitative efforts. Times where there's not enough providers, right? Many settings in our country, you don't have the luxury of the high amount of resources that we have in our system and in many of the systems on the call today, where you're able to put 5, 7, 10, or more providers on and get CPR for prolonged periods of time that remains high quality, right? If you're in a setting where you may have two rescuers and that's all that's coming, maybe mechanical CPR makes a little bit more sense in that setting where you know your CPR quality is going to fall off after the first 4 or 6 minutes. So, sort of different considerations. The door's left open for those. It doesn't say that you should not in those situations, right? Really, really leaves the door open. Again, not studied in those situations, so we don't actually know the effect in those situations, but we have a pretty strong hypothesis that it might be better. So, where's the evidence? We talked really briefly about this, right? These are really EMS-based studies. There's not a lot in settings outside of EMS, despite the use of mechanical CPR in several settings outside of pre-hospital care, whether that's in a cath lab type setting or in an emergency department or a hospital type setting, right? Where it's a bit different and less evidence is available. And so, a couple caveats that we always talk about when we talk about mechanical CPR, right, is you really have to watch the details. So the details with mechanical CPR are really, really critical. So this is your application times. We don't want your pause times to lengthen. We know the importance of our short, quick pauses. And then the other thing that happens with these devices is they tend to walk a bit. And so keeping an eye on exactly where your placement is and making sure that your placement is where you intend it to be as the provider, I think is really, really important. I've seen some systems take a Sharpie and sort of outline a circle with where they initially placed the suction cups in the Lucas device so they can know at a glance whether it has migrated or not and make appropriate changes. So just keep these things in mind. We're looking for really short application cycles. That takes a lot of work, a lot of practice to get good at. And then we're going to watch the placement after it's on and make sure it's good. Those aren't AHA recommendations. Those are my own advice and my own recommendations. All right, between 2020 and 2025, the following paper was published, right? And we've talked about this in detail. We've had Dr. Cheskis on for a very amazing webinar a couple years ago when the paper came out discussing defibrillation strategies for refractory VF, whether that's vector change or dual sequential defibrillation as the two studied alternatives to standard defibrillation. So I'm not going to spend a lot of time on sort of the challenges of this paper, the strengths of this paper, the weaknesses of this paper, but I am going to share with you a bit about what the recommendations are from the Heart Association. So the Heart Association really feels that after reviewing all the evidence, the science is not firmly established. And I think we would agree with that here at the Resuscitation Academy. So in direct wording, right, the usefulness of vector change defibrillation in adults in cardiac arrest with persisting VF after 3 or more consecutive shocks has not been established, right? And remember, that's the population that was studied, patients who were still in VF after 3 or more shocks on consecutive analyzing received either vector change, right? A second set of patches that went from either AP to anterolateral or vice versa. And then the second intervention that was studied was dual sequential defibrillation. Remember, in the study trial, the protocol was to put 2 defibrillators on, one AP, one AL, push the shock button 2 seconds apart, shock, and then shock, right? So the details here are really important because the technique itself is a bit still undefined and a bit variable depending on the operator. So when we talk about dual sequential defibrillation, that's the therapy that was described in the paper. That's the therapy that the Heart Association is talking about when they make this guideline, that the usefulness of dual sequential defibrillation in adults cardiac arrest, persistent VF after 3 or more shocks is not been established. And so really, I think conservative and appropriate guidelines here, not going beyond the evidence in any way, but instead sort of leaving the evidence there. And all this is issued with the clear knowledge that the 2030 guidelines will have significant more significantly more randomized trial evidence to base their recommendations upon, right? These are the four ongoing trials in Europe around dual sequential defibrillation. All have slightly different strategies. All I think will be interesting. All are in very high performing systems, most of whom are friends of the Resuscitation Academy. So we're very excited about seeing the results of these. I think we're still at least a year away from the first one being reported, but I think these will really inform a lot of knowledge around dual sequential defibrillation and when we should do it, how we should do it, if we should do it. All those questions I hope will be answered by these trials. So pretty excited to see that. Pretty excited to follow this evidence as we get into the 2030 guideline cycle. Looking forward. So more to come there. All right, a little bit of heads up CPR. Many of you are probably familiar with this. The origin story here is one of my favorite origin stories. This is scientist, inventor, cardiac arrest enthusiast Keith Lurie from the University of Minnesota going to visit some friends in Southeast Asia. And the question was popped, Dr. Lurie, we have these tall buildings with very small elevators. Culturally, we transport patients with ongoing CPR to the hospital. That's not going to change right now. What could change is should we load them in with their head up or their head down? And this simple question began a course of inquiry that led to pig evidence that perhaps patients with their head up do somewhat better at some of the invasive metrics of resuscitation. And out of that pig data came human cadaver trials, sort of a perfused cadaver model, and the implementation and sale of what's called the ELIGARD, which is a device to sort of deliver this heads-up therapy in a way that is optimal. To this day, no published human randomized controlled clinical trials of this device. There have been a couple groups that have tried to reproduce the pig lab findings and have struggled to reproduce those findings. And so I think the guideline that came out really sort of takes this into account. So heads up CPR in adult humans with cardiac arrest is not recommended except in the setting of clinical trials, which I think is a very appropriate guideline. I know there's even stronger feelings on this call by some that around this product and what should be the requirement for human subjects protection in any of its current use based on sort of the level of evidence that's available for this device. So that's the heads up CPR takeaway from the 2025 guidelines. So pretty strong work there from the American Heart Association in terms of using the evidence to inform the guideline. This one was a little bit surprising to me, right? So we've had the July webinar with Dr. Lars Anderson, who talked a little bit about the IVIO study that was done in his system. The guideline for me didn't quite follow all of that evidence and sort of steps a little bit outside of what I expected and what my interpretation of the data is. And so the guideline as published recommended that IV access for drug administration be the first attempt, and IO access is reasonable if attempts at IV are not successful or not feasible. I think the data is actually a little bit more equivalent than even this statement, where looking at the randomized clinical trials of IV versus IO, which is a big topic, could be an hour-long webinar all in itself, but really the differences are coming out to be less and less meaningful in the randomized clinical trials. And so I was a bit surprised by this recommendation. I don't know the details here on sort of when new evidence came out versus could be incorporated into this guideline cycle, as the randomized controlled research is relatively new within the last 12 to 18 months. But this one was a bit of a surprise for me. Vasopressor medications, not a huge change here. In consideration of timing, it's reasonable to administer epinephrine after initial defibrillation if attempts have failed. So this is the Heart Association saying, feel free to shock first and give medications after that, which I think is a reasonable approach. in many of our systems. And then relatively a change here, right? Vasopressin had sort of remained in the guidelines despite not a lot of data to support widespread vasopressin use, and really has come out for the cardiac arrest indication, where vasopressin alone or vasopressin in combination with epi offers no advantage as a substitute for epinephrine. So very appropriately, I think, following the evidence here around vasopressin and not recommending its use in cardiac arrest. All right, now we get to things that are back on the market, right? So mentioned in the guidelines, and I see a lot of chuckling on the screen. I'm sure you're chuckling at home too. Beryllium, right? So beryllium is back out there. I don't know who asked for it to be made, maybe nobody, but it is being manufactured and is for sale again in the United States. You can buy this and put it on your rigs now, depending on state and local protocol, and it is out there. However, there's really no evidence to support it. It has uncertain benefit, as the Heart Association says. So, and I agree with that totally. Beta blockers also fall into this category. So this is a question we often get at the Resuscitation Academy, right? Why don't we try esmolol for these patients, right? Why aren't we trying sotalol? Why aren't we thinking about beta blockers for these folks? It's a theory that's out there. There are a few sort of case report level evidence, but there's really not good evidence to support beta blockers. I think it would be a very interesting trial to run. I don't know if Big Beta Blocker has research funding to pay for said trial, but would be kind of an interesting experiment to really learn more about this. But in terms of evidence to support a guideline, right, there's just uncertain benefit and no clear role for beta blockers for beryllium, sotalol in treatment of VF and VTAC. The Heart Association lumped procainamide in there. I think some of us locally would disagree with that a bit, but I'll leave that for further debate. New this year is what I think is a strongly worded and fully endorsed by the Resuscitation Academy guideline that adult out of hospital cardiac arrest should receive compressions only TCPR guidance, right? Really should. The peds folks worked in there that instructions can include breathing for pediatric population, which does make sense. Peds patients are much more likely to have respiratory etiology to their arrest. And so if we're willing and able to provide breaths to peds patients, that can be a reasonable adjunct, but all should receive compression advice in cardiac arrest. And we know this is not universal, right? We all think it should be universal. We know that patients benefit from telephone CPR, telecommunicator CPR. And we also know that a significant percentage, 30 plus, last that I looked into it in detail, of telecommunications centers across the country do not provide the CPR instructions to patients that they presume are in cardiac arrest. So lots of work to do here, lots of work to do around quality, around improving, and around feedback to the dispatcher. Most of that didn't make it into the guidelines, but is stuff that you will see from the Resuscitation Academy over the next couple of years as we push further and further into TCPR and really work to benefit communities through this technique. A little bit of a stay and play. I know locally we like to call this remain and gain. I don't think counts as on, but this is one of how she's worded it, and I think it's great as well. I think the play moniker is a little bit of a demeaning one to our EMS personnel who are really spending a lot of time and effort on this. So in most cases, right, getting ROSC on scene, right, remaining and gaining on scene is preferable to transporting patients with ongoing CPR. You have to have folks who are empowered to do this, though, right? You have to have EMTs and paramedics in your EMS system who are adequately trained on both these kinds of efforts, but then also how and when to stop, right? When is it appropriate to terminate efforts, whether that's in conjunction with medical control or independently, depending on the system, and then how to handle that work, right? That's a whole body of work around how to tell someone that their loved one has died. And really there's a skill set there that we can tap into and try to improve the skills of our EMTs. We do call out one specific situation in the guidelines where transport with ongoing CPR may be continued. And these are sort of specialized centers where there is special services available. And ECMO is the one that is specifically called out, where field ECMO is not widely available but ECMO in an emergency department may be more available. There may be a situation where transport with ongoing CPR is reasonable in the setting of heading to something different in the hospital. To make that sort of a routine thing for all cardiac arrests, I think is not the recommendations from the Heart Association, and nor from the Resuscitation Academy. We feel strongly that staying on scene is really an important part of successful resuscitation, wherever that is appropriate. But we also support sort of the innovation and work that can occur with some of these advanced sort of sprinkles on top of the icing on top of the cake of resuscitation, right? We're really, when we talk about ECMO programs, we're talking about helping very small numbers of patients in the big scheme of cardiac arrest. So exciting to see it in here, and more to follow as these programs grow, mature, develop, and figure out exactly who the right patient is for cannulation and for ECMO support. A little bit of a shift in LVADs, and I think this might be the last time I can use my picture of the most famous LVAD patient we've had in the US in recent years, as he has now passed away. Vice President Cheney was a longtime LVAD destination recipient. I don't know about standing in front of a crowd and waving the battery from your LVAD around. That's a whole level of risk that just seems unnecessary, but I'll let Vice President Cheney and his doctors handle that. The change from the Heart Association is really an update in the algorithm, and there used to be some information in here about sort of trying to assess perfusion in these patients and really trying to dive into some of the details. And I think the algorithm was shortened and tightened up in a good way, in a patient-centered way, where we're just sort of, if they appear to not have adequate perfusion, we're not trying to, do a map with a Doppler. We're looking at a patient who has an LVAD, we're seeing the LVAD, and we are diving into sort of chest compressions if they appear to need chest compressions based on everything that we assess for all of our patients and sick, not sick type paradigm. Right. And so starting compressions and then getting a second rescuer in to start to work on device related reversible causes. Is there a battery that died? Has the battery become disconnected? Is there a wire that's disconnected from the power source? Or are there preventable things that we can do to fix these and to really dive into why this patient is hypoperfusing immediately? Then lots of post-arrest updates. Most of them are a bit beyond sort of the scope of this webinar and really get into the nitty-gritty of the critical care, both on the pediatric side and the adult side, which I think is really great. Good to have widespread recommendations that are evidence-based on these. The one I wanted to highlight was actually based on work here at the University of Washington, and I think is pretty interesting. It's been interesting to me, at least, as I follow our patients who suffer cardiac arrest. So this is the concept that it may be reasonable to perform sort of a CT pan scan, as we think of it in the emergency department. This is a head to pelvis CT scan for patients, adult patients after ROSC, looking for both why did they have the cardiac arrest? Do they have some undiagnosed, unsuspected etiology that we can catch with this imaging modality? And then also, are there any complications from resuscitation? And these can be sort of liver, splenic lacerations, occult pneumothoraxes that might not show up on a chest X-ray, pulmonary contusions, which are fairly common in these post-resuscitation patients. Really looking for CPR-related, resuscitation-related injuries and expediting their treatment, right? And we have a whole series of these that have been found within our sort of group of cardiac arrest patients, whether they were in this CT scan era or the pre-CT scan era, where they'd have a liver laceration, wouldn't be caught for a day or two. The ICU docs would be troubleshooting the hypotension and really working to figure it out. And finally, we get a CT scan and find that there was a bleeding liver laceration. And they were actually dealing with mixed hemorrhagic shock, mixed with sort of cardiogenic shock post-arrest. And so this imaging modality, I think, has really helped to speed up the patients who have sort of this post-cardiac arrest care plan, and really allowed us to find some things earlier and intervene earlier before we have sort of some chronic sequelae and perhaps even secondary fatalities from these things. Literature, up to 30% of these scans have clinically significant findings. I think that's a bit high, but we do find a significant number of findings in this population that are actionable and make a difference for the patient in their outcome. So pretty exciting work here, and more to come in the future around this kind of work. Point of care ultrasound is also called out as reasonable post-arrest for similar purposes. I think Heart Association has really stayed out of sort of intra-arrest POCUS. The evidence is not super strong for this kind of technique, and the evidence that is out there shows longer pauses, longer pulse checks, things like this that are not sort of patient-centered outcomes. Michael, I see your hand up.
Yeah, I was
Free to
just going
chime in.
back to the head to toe CT or head to pelvis CT or the sudden death CT.
Yep.
And wondering if any of the people who are on the call, maybe who work in hospitals, could just put in the Q&A whether their hospitals are doing these on like all people with ROSC or just selected ones. I'm curious how widespread this practice actually is.
Yeah, I actually gave this talk at a conference I was at last week to emergency medicine doctors, and this was probably the biggest point of conversation. I think it is not widespread, and is still relatively new in the EDs around the country. So I think this is good to have called out in the guidelines, and I think is interesting and compelling for the care of our patients.
Yeah, and I bet they get trauma pan scan uh, with a very low threshold.
Right?
Um,
Yep.
so
Janet Trethway, this is the recommendation for all hospitals in Montana from the state trauma care committee. So I think that's great. And is evidence-based and now part of the guidelines. So super cool. If we get any more comments on this, I'll try to chime them out and bring them back in. There was, a little bit of sort of post-ROSC work, and I think, what really stood out to me around some of this post-ROSC work, and specifically, was neuroprognostication, right? And the complexity of neuroprognostication continues to grow as we have more tools to use to really help with our patients. I think there's a lot that we are learning and continuing to learn, and I think that will continue to evolve over the next 5 years pretty dramatically, and we'll hopefully learn even more about sort of who is a potential survivor, and who sort of can have early neuroprognostication. And so what I think is really important is to resist that urge, both within EMS and really within sort of emergency medicine too, to do that neuroprognostication early. I was working a clinical shift earlier this week and working with a resident, very well-meaning, very smart resident, and the resident was sort of in their initial exam of this post-ROSC patient is sort of looking at pupillary reflexes and trying to draw conclusions from that. And so we had a long conversation about, what value is there to pupillary reflexes in this, immediate post-ROSC setting. And the value is really pretty minimal, right? That doesn't help us predict who's going to survive their cardiac arrest and who's going to have a good neuro outcome. And so I think really resisting that urge for our EMS providers and really delaying that until we can get good, high quality information on our patients to really give accurate neuroprognostication is of pretty strong value. And I was struck by the complexity of this recommended exam, in addition to sort of all the additional experimental therapies that are trying to drive into this, and experimental evaluation work that is ongoing here. And I went back to an old Peter Kudenchuk Resuscitation Outcomes Consortium paper, right? I think this holds true today, even, almost 10 years later, that early withdrawal support leads to decreased survivors. And there are some patients who would otherwise survive who have their support withdrawn within the first 72 hours, and it's not sort of something that we want. So really continuing to dive into this work and continuing to understand the complexity here, and where we can pluck survivors from the bigger population, I think is really important. I put in one of my favorite slides from the last year. This is our friends at Best EMS and the Dallas Fort Worth Department of Public Safety at the airport. And two things here that I think are worth talking about. The first is that we are recognizing survivors. We are reuniting survivors with the crews that cared for them, and we are sort of helping to sort of recognize that there's a whole population here. And this population gets to come back and get their ticket to ride, right? And ticket to survive and get recognized by some of our EMS colleagues and get to meet their folks. And some of these are local to the Dallas-Fort Worth area. Some of these are folks who were traveling through and then make the effort to come back and reunite with their rescuers. Super, super cool. What I don't understand, and maybe Dr. Ray, you can enlighten me here, once these folks have survived their cardiac arrest, right, and they're doing well, they're back on their feet, they're back to work, back with their family and their loved ones. Some of them come back. They get to pick their seat for eternity here on the 757, 7 whatever, 777, whatever seven this is. And some of them pick a middle seat. And this boggles my mind that you survive your cardiac arrest. There are open aisle and window seats, and you pick a middle seat. I don't understand that. So maybe someday you can enlighten me on the mindset of maybe those are the ones that are not quite neurointact. Is that what
Could
we're?
be that. I'm liking that answer. Yeah.
But this is super
I
cool.
don't
We've
mind
seen,
being in the middle seat.
yeah,
So
exactly. It's okay.
they're
These
happy to
forms
have
of
any seat on the plane.
Yeah, exactly. These forms of public recognition I think are awesome, and I just wanted to call out this as one of them that we've seen this year that just speaks to me and I think is really really cool and something that we want to continue to endorse and support in all the work that we do. So super super cool. One bonus topic thrown in, if you've been to any of Peter Kudenchuk's question and answer sessions over the years, you've heard him talk about if you're doing cardioversion, right, just start with 200 joules and cardiovert the whole heart instead of the 100 joules that heart has previously recommended. Here's the meta-analysis that proved him right, and then the guideline to follow the meta-analysis, where 200 joules is a good place to start for synchronized cardioversion with a pulse. Go ahead and start at 200 joules. You're more likely to convert on that first shock and somewhat more likely to convert cumulatively if you give a good shock on that first attempt. So a little outside the cardiac arrest world, but we'll allow it with our electrophysiology emphasis that we have here around the Resuscitation Academy, and we'll talk about it briefly. That's all I had. I'm gonna stop sharing here, and I'm gonna ask a few questions, and I think I'm kind of interested to hear Tom and Michael's opinions around some of what really stood out to them with the 2025 guidelines and kind of what they think will be really practice changing and drive things forward. So I don't know who wants to start, but feel free to jump in and kind of share your ideas and thoughts.
Well, I'll jump in first, Andy. Thanks for putting together that slide deck and running through all these things. I guess to me, couple of I was struck by a couple of things. So one is true in the past. The team that organized and executed this just did a ton of work. And I hope the people on the call appreciate those group of volunteers that didn't get paid to go through all these studies and organize this information. At the same time, almost none of the new information comes from the United States. And I think that is due to a variety of factors. One of them being the regulatory challenges of organizing and executing these studies, which are not inexpensive. Pretty steep price to do an out-of-hospital cardiac arrest trial. And then it's just so difficult to get them funded. Mm-hmm. So kudos especially to people in places like Denmark, Sweden, Norway that are doing these trials today, and Australia, and a few other countries where it's still possible, Canada, to do these randomized trials.
Yeah, so I concur with Michael on this for sure. This is a big lift, even though the output may not feel like it's there are a lot of changes, day to day practical implications, but just doing the reviews and I think understanding that they need to put all these things into context is really a remarkable effort by a lot of people from a lot of places, and so it's much appreciated that this is a service that is provided to us in resuscitation. I think you covered the landscape quickly and well, Dr. McCoy. I was impressed, and I guess I was going to mention, if you didn't mention this idea of the stay on scene
Mhm.
and attempt ongoing resuscitation instead of the sort of the primary approach is to sort of package that patient as quickly as you can on the route to hospital. It would be very interesting if some of our colleagues in Southeast Asia, where that is the routine, maybe I think still in Japan as well, where they move almost immediately to what would happen to their survival if they gave folks the skills and the resources. And I think they, in some of places, they do have the skills and the resources to
Yep.
do that work on scene and see how it might impact survival. Because the observational data, which comes from, I think, mostly from Rock, and good work from Brian Grinnell,
Mhm.
and I think folks at Pittsburgh who have done this work in peds, is that it's associated with a twofold improvement in outcome. Now, the reality is it probably won't result in a twofold improvement, but even if it was, somewhere between one and two, it might be pretty important because a lot of systems in a lot of places, maybe not so much in the US anymore, move pretty quickly to move patients. So it'll be interesting to see if other places adopt that strategy because it is a big lift, right? You got to train people to do care for more than the first 10 or 15 minutes. But I thought that was an important recommendation that came from that observational data.
Couple comments in the chat. Bill Tunes talking about, and I think this is really an important addition to what I talked about. It is good to know, and I agree there are many EMS providers on many of the different AHA review teams, right? And so the field provider does have a seat at the table. It may feel sort of heavily dominated by academics and doctors, and to some extent it is, but there is also where appropriate, an EMS seat at the table. And I think that's really a valuable perspective. And I appreciate you offering that up, Bill. Thank you very much. Another question in the chat. If we have mechanical CPR due to low manpower, are there recommendations for time off the chest and sort of how to handle the switch from manual to mechanical CPR? 10 seconds question mark, which I think is a good question mark. And I would say less if you can do it. We've had many systems both locally and in our Lighthouse network that have made this change for one reason or another. It takes multiple rounds of training to get really good at this. We know that. We also know that it can be done in as little as 5, 6 seconds, right? When I saw the demo at Best EMS a few months ago, it was quick. It was quick. It was in the 5, 6 second range, right? With lots of practice and lots of effort. And so really trying to minimize that time is going to be the best thing for your patient. And the way to do that is just to practice and practice, practice. No AHA guidelines on this that sort of specify the exact number. It's all based on sort of seeing what folks are able to actually accomplish in real life. I don't know if either of you have anything to add to that. Feel free. Yeah,
Yeah,
go
I
ahead.
mean, I think that's what you get with a lot of training, not just once in a while training.
Training, ongoing training, and practice regularly, right? Yeah.
Yeah, I think the natural experience is if you don't do that, it's somewhere between 30 and 60 seconds. Well, I mean, that was some of the original experience, I guess, that it was communicated to me by folks like Mike Livy and others, that if you don't really focus on it you will interrupt your CPR by 30 seconds or more. Um, but but I think that's I think the other consideration in this is when you initiate, right? So there's not a standard, but I think everyone recognizes you don't start with mechanical, right? You start with putting hands on the chest at least initially to get those first rounds of CPR and rhythm analysis, et cetera, underway. And so, when do you choreograph that implementation? And I don't know the answer, but I do think some of those systems really work at starting at a point when everyone feels they're ready to go on the mechanical stuff. So yeah, it's an art as well as a science, I think.
Question in the chat, are there any ongoing studies for mechanical CPR versus manual? I don't know of any that are actively enrolling patients to compare the two. I don't, that I see Tom. Yeah, I don't. Okay.
I
So
mean, maybe
no,
there are, but I'm not aware of one.
yeah, none that I know of either, both within the US or outside. So. Let's see. Yep. Pediatric ventilations. Do either of you have any comment on the pediatric ventilation topic?
I have a comment on ventilation in general.
Okay,
And
we'll take it.
I think this is certainly an area of active exploration with many ongoing observational studies. And we're doing an intervention trial in Seattle, King County now, thanks to Tom Ray, sort of exploring methodology. But I think we just don't know much at all about ventilation because we've never really been able to measure it. And then finally, we were able to do a bit of measurement, and better measurement tools are likely to emerge. And I predict that this will, over the next 5 years, be a big driver of the 2030 guidelines.
Yeah.
So, getting the oscillations in the capnogram is definitely a marker of improved survival. Whether why that is exactly true isn't clear, but probably because it reflects just an open ventilation circuit with somebody pushing on a chest and they're moving a column of air up and down, which is good. And so, could it be possible that smaller, more frequent breaths, which is kind of what the pediatricians are advocating for, is actually better? I think it's totally possible. And we just need people to do the studies to kind of explore this more.
Yeah, I think this is definitely, I totally agree with you. This is an area of huge work right now, right? And I think it's a really important area that's been neglected in the past. So more to come, and more to learn for sure. Ryan Sullivan in the chat, many EMS services are switching to mechanical ventilation. Any studies to support mechanical ventilation or not with extensive training? Not a lot out there. There are a few sort of ongoing trials in Europe trying to explore some of the newer strategies with mechanical ventilation. Whether those will work or not is a big question mark. And then sort of thinking about what to do intra-arrest versus post-arrest are both big question marks. I think perhaps we will find evidence over the next 5 years that a device is more consistent than a human being. That would not surprise me. You don't think so?
No, it's going to replicate mechanical CPR for the exact same reason.
Maybe, maybe,
Yeah.
maybe. That's an interesting hypothesis. Hadn't thought about it that way. So, yeah, yeah,
And the fundamental reason is we don't know what they should actually do in an individual patient.
that's fair.
And so you're applying a one-size-fits-all strategy to a very heterogeneous population of patients.
Yeah.
And
Yeah.
so the mean will maybe be about the same.
We'll see. We'll see. This will be fun. All right, one challenging question from a Chicago friend. There is an EMS medical director in our area with protocols that prohibit defib or epi in VF unless end tidal is 20 or greater. Tom Ray, give me your hot reaction.
Okay. I mean, so the idea here is that the patient has more viable protoplasm, and so they will respond favorably to the epi and the shock as
Yeah,
opposed.
I think this is Peter's priming the pump and
Yeah.
building up a ATP idea, and perhaps it's some of the waveform of VF getting more likely to receive a shock kind of concept working its way into
But
this.
I guess the question is what to do. What do you do for the other patients? Like, do you not treat them, or you just do CPR until though they get those end tidal greater than 20? I mean, a lot of those people won't attain that level, and so do you just throw out your other therapies? That's a tough situation. I guess I'd ask, what's the option for these other patients?
Yeah.
Because there are lots of them that don't get to that mark. So,
Yep.
and I hope they're measured
Yeah,
much.
to the extent that an end tidal less than 20 is a marker of a problem with chest compressions, then it
Maybe.
feels like, at least in some of the patients, mostly it's not, but in some patients it certainly is. Then I'm not clear maybe how epi would solve that problem, for one thing, but withholding defibrillation feels a little counterproductive, especially if they're presenting in VF. I don't know. There might be more to that story.
Let's do one last question and then we will wrap up. Thoughts on initial pad placement, AP versus anterior lateral, and sort of where should we start with our patches when we're putting them on the chest? I think it's an interesting question. We've talked a little bit about it in past webinars. I think we'll talk more about it in the future as I think more literature comes out. Any commentary?
It's a great
I'll
question.
just say that it's an interesting question. The effect size in Canadian trial was small,
Mhm.
and that was after several failed shocks, allegedly failed shocks, I should say. And so, you know, seems reasonable in that circumstance to give it a whirl as long as you can do it without a big break in
Yep.
CPR. So I think that's my current approach.
I think that makes sense. Something to think
And
about.
importantly, you got to get the lateral pad in the right place. It's really lateral and with the top edge at the nipple line.
Yep.
So you actually are sending electricity through the heart.
Yep. Getting that. The meatloaf sandwich is Dr. Kudenchuk would describe it were he not in clinic right now. Exactly. You got it. You got it. Sandwich that heart between your patches so
Meatloaf, meatloaf, right? Yeah.
Awesome. Well, thank you everyone for joining us today. I do have to say and share a bit that Tom Ray's birthday was just a few days ago.
Oh, yes, indeed it
Uh,
was.
so you're not escaping without a hearty happy birthday, Dr. Ray, from me and the 100 or so on our webinar today. So happy birthday, another trip around the sun, and congratulations. I don't think it was a big milestone. At least I didn't hear that it was a big milestone. So we won't.
It was a medium milestone.
Was it? Oh, there
Oh,
we go. We'll break out the
yeah.
Black
It
Walker and I'll
ended in a
deliver it to your
0.
office.
Uh,
Excellent. Happy birthday, and thank you all for attending. We'll be back in January, and we're getting a really great lineup for 2026. We're super excited to have everybody join us, and we'll see you in 2026.